Hello, everyone. This is Eric Strong from Stanford University and Strong Medicine, and this is the last video in this series on hemostasis. Today, I'll be discussing some clinical vignettes covering uncommon situations involving disorders of hemostasis, accompanied by some board-style multiple-choice questions. Let's get started. Case 1. A 60-year-old man presents with 3 months of headaches and recurrent episodes of red discoloration and hot, burning-like pain in his fingers and feet. His past medical and surgical histories are unremarkable. Physical exam reveals splenomegaly. Labs show a white blood cell count of 6, hemoglobin 19, and platelets 850, that is 850,000. Which of the following is the most likely diagnosis? Pause the video to look over the answer choices, and once you've committed to an answer in your head, hit play. The correct answer is C, polycythemia vera. Polycythemia vera, often known colloquially as P. vera, is a myeloproliferative neoplasm characterized by increased red cell mass, usually identified on labs as an unusually high hemoglobin. A significant minority of patients with P. vera have thrombocytosis in addition to the elevated hemoglobin. Regarding the other answer choices, choice A, essential thrombocythemia, can present very similarly as P. vera, but is not associated with an elevated hemoglobin. For choice B, secondary thrombocytosis, in which a patient has an elevated platelet count for a reason other than a primary hematologic malignancy, for example in response to an acute infection, anemia, or following splenectomy, none of these appear to be present here. Choice D, acute leukemia, can be associated with elevated platelet count as well, but are associated with a high white blood cell count, not a high red blood cell count. Next question. What is the medical term for the episodes of painful discoloration of the extremities which the patient is experiencing? This is called erythromelalgia, and in addition to burning pain and erythema, there can also be transient pallor and cyanosis. The episodes can be triggered by exercise, warm temperatures, including wearing heavy socks, and the ingestion of alcohol. Regarding the other choices, erythroderma is a general term to describe intense diffuse redness of the skin associated with inflammation. Although erythroderma is associated with many different diseases, including hematologic malignancies, when it occurs, it is not limited to the hands and feet, generally occurs over the entire body, and it doesn't typically come as discrete, repetitive episodes. Petechiae are pinpoint, round, red, brown, or purple, non-blanching spots in the skin and mucous membranes caused by tiny hemorrhages in the dermis, predominantly caused by very low platelet counts. Allodynia is a symptom in which patients experience pain in response to stimuli not normally painful, for example, a sheet being gently pulled across the skin. Allodynia has nothing to do with disorders of hemostasis. Next question. Which of the following additional symptoms are classically associated with the patient's likely diagnosis? The answer is B, aquagenic pruritus. This is the name given to the phenomenon in which contact with water induces intractable itching. In addition to P. vera, it is also occasionally seen in T-cell lymphomas. Regarding other answer choices, gum bleeding with toothbrushing is a classic symptom of either thrombocytopenia or disorders of platelet functioning, including von Willebrand disease. Palpebropurpura are elevated, firm, hemorrhagic plaques, most commonly observed in the legs. It is more typically observed in vasculitis or inflammation of blood vessels, rather than in a primary hemostasis disorder. Easy bruising is very nonspecific, but is most typical of deficiencies of coagulation, such as hemophilia, or more commonly seen in patients on anticoagulation. This condition is associated with a mutation in which of the following genes? The answer is D, Janus kinase 2, better known by the name of its gene, JAK2. This protein is part of signal transduction in response to activation of cytokine receptors and is important in hematopoietic cell proliferation and differentiation. Mutations in both the genes for prothrombin and antithrombin can cause an inherited form of hypercoagulability, neither of which is associated with an abnormal CBC. Mutations in the MYH9 gene encoding myosin 9 lead to a genetic disease unoriginally called MYH9-related disorder, which can manifest as thrombocytopenia, renal failure, hearing loss, and cataracts. Moving to the next case, a 35-year-old woman presents with a 1-week history of progressive right upper quadrant pain and abdominal distension. Upon further questioning, she also reports a 6-month history of progressive fatigue, dyspnea, decreased exercise tolerance, and occasionally brownish urine. Her past medical and surgical histories are unremarkable. On exam, her pulse is 110, blood pressure is 120/80, she has icteric sclera, abdominal exam reveals generalized distension, splenomegaly, and a tender enlarged liver. Labs are notable for an AST 200, ALT 220, total bilirubin of 5, white blood cell count of 5, hemoglobin low at 7.5, platelets 130, and reticulocytes markedly elevated at 8%. Both her INR and PTT are normal. A CT scan of her abdomen and pelvis reveals hepatic vein thrombosis, a condition also known as Budd-Chiari syndrome. Which of the following is the most likely diagnosis? The answer is D, paroxysmal nocturnal hemoglobinuria. This rare disease manifests as a combination of hemolytic anemia, bone marrow suppression, and thrombosis in unusual locations, particularly intra-abdominal veins and cerebral veins. Despite its name, the classic presentation of paroxysms of hemolysis occurring at night is actually atypical for the disease. In this particular case, the elevated AST and ALT are secondary to the Budd-Chiari syndrome rather than a direct consequence of the PNH. The elevated total bilirubin is a combination of liver dysfunction and hemolysis, and the low platelets is probably a result of sequestration of platelets within a pathologically enlarged spleen, which itself is related to the acute liver dysfunction and thrombosis. Factor V Leiden and antiphospholipid syndrome are both hypercoagulable states, but they are not associated with a hemolytic anemia. While answer choice C, hemolytic uremic syndrome, does lead to hemolytic anemia, it is not a hypercoagulable state and is not associated with hepatic vein thrombosis. HUS is also a more acute disorder that would be highly unlikely to have existed for 6 months before presentation. The best test to confirm a diagnosis of paroxysmal nocturnal hemoglobinuria in this patient would be answer D, flow cytometry. Flow cytometry is a lab technique in which a sample containing cells is suspended in a fluid, which is then focused such that one cell at a time passes through a laser, where the pattern of reflected light can identify specific cell characteristics. In the case of PNH, the cells are first labeled with monoclonal antibodies against GPI-anchored proteins, which are lacking in some blood cells in PNH. Regarding answer choice A, a peripheral blood smear would be useful at ruling out other causes of hemolytic anemia, but there are no findings that point specifically towards PNH. A bone marrow biopsy is performed in PNH when there is concurrent significant leukopenia or thrombocytopenia to rule out marrow failure as a contributor to the presentation, but it is not necessary for the initial diagnosis and would not be indicated in this particular case, as the patient has a clear alternative explanation for the relatively mild thrombocytopenia. A liver biopsy would only identify features consistent with the patient's hepatic vein thrombosis. It would not provide any useful information regarding the cause of the thrombosis. Which of the following is the mechanism of pathogenesis in PNH? The answer is B, an acquired mutation. PNH is caused by an acquired mutation in the PIGA gene occurring in a hematopoietic progenitor cell. The PIGA gene encodes an enzyme necessary for the synthesis of a glycosyl-phosphatidyl inositol, or GPI anchor, that attaches some proteins to the cell surface. The causative mutation cannot be inherited because it is lethal during embryogenesis. Regarding choice C, autoimmunity is responsible for a few disorders of hemostasis, but PNH is not one of them. Which of the following is a classic complication of PNH? In addition to hemolytic anemia, bone marrow failure, and thrombosis in unusual sites, other classic complications of PNH include dysphagia, chronic abdominal pain, and pulmonary hypertension. While PNH can cause both acute and chronic kidney disease, it does not typically cause nephrotic syndrome per se. Also, neither hearing loss nor skin ulcerations are associated with PNH. A 10-month-old boy who had displayed normal development up until now is brought to the pediatrician by his mother because he stopped crying over the preceding several days and has not been sleeping as well. She reports that a large bruise has shown up on his right leg. She reports no previous problems with bleeding. The mother's brother died from a stroke when he was a child, but she does not know any details about any specific diagnosis. Neither of the mother's parents nor the boy's father have any bleeding tendencies. On exam, the boy's vitals are normal. His right thigh is warm and swollen with overlying ecchymoses. Several other small ecchymoses in various stages of resolution are noted in his extremities. His CBC is normal, INR is 1.0, and PTT is 55 with a normal range of 20 to 35. Which of the following additional lab abnormalities would be most likely observed in this patient? The answer is choice A, low factor VIII activity. This is a typical presentation of hemophilia A, which is characterized by low factor VIII activity. Hemophilia has a broad spectrum of clinical severity depending on the amount of residual factor activity. Usually, factor activity below 40% is required before a patient is considered to have hemophilia and be at an increased risk of bleeding. Within the spectrum of 0 to 40% activity level, the initial presentation can occur at the time of birth for infants with less than 1%, or in late childhood, or even later for those with 40% activity. For this patient, in addition to the ecchymoses and what may be an intramuscular hematoma, which has a number of different explanations by itself, the family history of a potentially fatal bleeding complication is suggestive of an inherited bleeding disorder, and the very elevated PTT suggests a problem with the contact activation pathway or intrinsic pathway where factor VIII is located. While a factor VIII inhibitor could cause the same lab abnormality and present with spontaneous bleeding, it is far less likely in an infant. Factor VIII inhibitors tend to be seen in older patients who have had severe hemophilia for many years, as well as being very rarely seen in patients with rheumatoid arthritis, lupus, malignancies, or in the postpartum period. An elevated PTT should correct during a mixing study, and this is one of the primary pieces of evidence that an individual has hemophilia to begin with. And regarding choice D, while there are inherited diseases resulting in absent, low, or dysfunctional fibrinogen, they are far more rare than hemophilia and classically cause an elevated INR and PTT. If testing confirms a low factor VIII activity level, the boy should be screened for which of the following additional diseases? The answer is D, von Willebrand disease. Von Willebrand disease is caused by deficiency or dysfunction in von Willebrand factor, which, in addition to playing an important role in platelet function, also inhibits proteolytic inactivation of circulating factor VIII, increasing its half-life in the circulation. Thus, severe von Willebrand disease could also present with spontaneous bleeding in childhood and a low factor VIII activity level. Wiskott-Aldrich syndrome is a rare genetic disease that manifests as thrombocytopenia, immune dysfunction, and eczema. It does not cause prolongation of the PTT. Glanzmann thrombasthenia is an inherited qualitative platelet defect. While it can present with spontaneous bleeding and normal platelet count, it also does not cause an elevated PTT. And protein C deficiency is an inherited cause of hypercoagulability rather than an increased bleeding tendency. Testing for von Willebrand disease is negative, and a diagnosis of hemophilia A is confirmed. If the boy has a twin sister, which of the following is most likely to be true? Answering this question requires both knowledge of hemophilia A's inheritance pattern and what that inheritance pattern looks like in classical Mendelian genetics. The gene for factor VIII resides on the X chromosome, so a female with one defective copy of the factor VIII gene will generally be a carrier for hemophilia and not have the disease themselves, so in short, the disease is considered to be X-linked recessive. Let's construct a probable pedigree, keeping in mind that there will be some assumptions here. We know that the boy has hemophilia A. Since male offspring inherit the X chromosome from their mother and the Y chromosome from their father, this makes the mother a presumed hemophilia A carrier. The boy's mother stated that the boy's father has no bleeding tendency, so we can make an imperfect assumption that he does not have hemophilia A himself. And there really isn't such a thing as an asymptomatic male carrier of hemophilia. Although the boy's sister is a twin, they're obviously non-identical, so therefore the probability that she has inherited certain alleles from her parents are the same as if she were a non-twin sister. Since the sister is female, we know that she must have inherited the normal X chromosome from her presumably non-hemophilic father, and she can inherit either of the two factor VIII genes from her mother, only one of which has a mutation for hemophilia A. So with this, if we look over the answer choices, all choices but B are ruled out. Regarding B, while there is only a 50% probability that the sister has hemophilia A, this is more than the other three choices. Now, to be clear, in reality, the inheritance pattern and probabilities of a genetic disease within a pedigree is rarely as neat and clear as classical Mendelian genetics would suggest. For example, a significant number of cases of hemophilia are caused by de novo germline mutations in which neither of the parents are carriers. There's also another possibility that's far less likely, but not impossible, that the sister has inherited a defective factor VIII copy from her mother and has a de novo mutation in the other factor VIII gene, resulting in the sister also having hemophilia A. But these and other unusual variations are less likely than the boy's sister being a hemophilia A carrier. Which of the following statements about hemophilia is true? The answer is D. The term hemophilia C is sometimes used to refer to an extremely rare inherited deficiency of factor XI. Now, even if you have never heard of hemophilia C, you could have successfully chosen the correct answer by eliminating the other choices. First, with choice A, hemophilia A and B do not have roughly equal prevalence. The prevalence of hemophilia A is approximately 3 to 5 times higher than that of hemophilia B. Regarding choice B, hemophilia A is caused by mutation in the gene for factor VIII, while hemophilia B is caused by mutation in the gene for factor IX. And regarding choice C, hemophilia A and B are more or less clinically indistinguishable. While at least one study has found that hemophilia B tends to be slightly more mild in severity than hemophilia A, the most common sites of bleeding are nevertheless the same. Case 4. A 40-year-old woman, previously healthy, presents to a primary care doctor with 1 week of fatigue, headache, foggy thinking, and abdominal pain. These symptoms have been progressively worsening. She has no relevant past medical history. On exam, her temperature is 99.2 Fahrenheit, pulse is 110, blood pressure 130/80, respiratory rate 20, O2 sat 99% on room air. Her abdominal exam is normal. Skin exam reveals diffuse petechiae, and neuro exam notable for subtle word-finding difficulties and below normal attention. Notable labs include a white blood cell count 8, hemoglobin 7, platelets 25, reticulocytes 10%, Chem 8 is normal, and LDH is 800, when the normal range for LDH is less than 250. Schistocytes are seen on a blood smear. Which of the following lab profiles would be most consistent with a diagnosis of thrombotic thrombocytopenic purpura? Before answering, just to remind you of how TTP presents, it has a classic pentad of manifestations, microangiopathic hemolytic anemia, thrombocytopenia, fever, renal failure, and neurologic symptoms. However, the majority of patients diagnosed with TTP do not have all 5 of these manifestations at the time of diagnosis. In addition, although it's not part of the classic pentad, abdominal pain is relatively common. So based on those features, we know that hemolytic anemia is usually present, limiting our possible answers to 2, of which the one that's correct is answer C, as TTP does not typically cause prolongation of INR or PTT. In contrast, choice A is most consistent with acute DIC, choice D would be seen in immune thrombocytopenia or ITP, and choice B really isn't a classic pattern seen with any remotely common disease, and when encountered in practice, may be most likely either an atypical pattern in a patient with acute DIC, or seen in a patient with 2 different concurrent diagnoses to explain the low platelets and high PTT. Which of the following mechanisms is responsible for the majority of cases of TTP? The correct answer is C, an autoantibody against the ADAMTS13 protein. Although TTP can also be caused by an inherited mutation in the ADAMTS13 gene, this is rare. Inherited mutations in the von Willebrand factor gene cause, unsurprisingly, von Willebrand disease. Infection with an enteric organism that produces Shiga toxin is responsible for hemolytic uremic syndrome, which shares some clinical features and elements of pathogenesis with TTP, but which is considered to be a separate clinical entity. What is the normal function of the ADAMTS13 protein? The ADAMTS13 protein is responsible for choice B, breaking down von Willebrand factor multimers. Choice A, the protein responsible for cleaving fibrin, is called plasmin. Choice C, there are many tyrosine kinases involved in cell signaling, but one that has been discussed in this series on hemostasis is Janus kinase 2, also known as JAK2, which was discussed as part of case 1. Choice D, the protein that acts as a receptor for fibrinogen, is glycoprotein 2b3a. An ADAMTS13 activity level is confirmed to be extremely low, less than 10%, in this patient. All of the following treatments are indicated at this time, except. The answer is D, platelet transfusion. Even though thrombocytopenia is a central characteristic of TTP, life-threatening hemorrhage is rare, and indications for platelet transfusion in TTP are generally similar to patients with other causes of thrombocytopenia. With a platelet count of 25 and no active evidence of bleeding, there is no indication for platelet transfusion at this time. Regarding the other answers, all patients with a confirmed or presumptive diagnosis of TTP should receive plasma exchange immediately, which physically removes the autoantibody causing the syndrome. Plasma exchange is necessary rather than just plasmapheresis because the latter does not replace the lost ADAMTS13. Steroids reduce the production of the autoantibody and are also indicated in all patients with confirmed or presumed TTP. Rituximab, a monoclonal antibody directed against CD20, also reduces antibody production and is indicated for all patients with confirmed TTP who have extremely low ADAMTS13 activity, as this patient does. The last case of this video. A 30-year-old man is establishing care with a new primary care provider. He reports that he has been generally healthy his whole life. His only symptoms of any significance are gum bleeding with toothbrushing and occasional nosebleeds, the latter of which he attributes to dry air in his home. On exam, he has normal vitals. Mild petechiae are present on his arms and legs. The remainder of a thorough head-to-toe exam is normal. On labs, his white blood cell count is 6, hemoglobin is 13, and platelets are 20. A Chem8, INR, and PTT are all normal. Which of the following is the most likely diagnosis? The answer is A, immune thrombocytopenia, better known as ITP. Von Willebrand disease can have the same history and exam as this, but the typical lab findings are a normal platelet count and elevated PTT. Bernard-Soulier syndrome is an example of an inherited giant platelet disorder because on blood smears, the platelets appear unusually large. Although it can also cause thrombocytopenia, it is much more rare than immune thrombocytopenia. Antiphospholipid syndrome is an acquired hypercoagulable state associated with normal platelet count and elevated PTT and looks nothing like this particular patient's presentation. Which of the following would be the most likely finding on a blood smear? The answer is C, reduced platelet count but otherwise normal. Regarding choice A, although ITP can cause some unusually large platelets on smear, they are not all large and are not large enough to be classified as giant. The specific size cutoff often used to refer to a platelet as a giant platelet is greater than 7 microns, which is the approximate size of a red blood cell. Regarding B, platelet clumping is predominantly a lab artifact caused by the anticoagulant EDTA, which is found in some blood collection tubes. And schistocytes are red blood cell fragments seen in TTP and DIC. A blood smear shows only low platelet count without morphologic abnormalities of any cell lines. For which of the following diseases should the patient also be screened? The correct answer is D, HIV. HIV is a well-described cause of thrombocytopenia through bone marrow suppression that could be mistaken for ITP, but it is also associated with ITP. Given this association and the ease with which it can be screened for, HIV testing is recommended for all patients who are about to be given a new diagnosis of ITP. Pancreatic cancer is associated with chronic DIC and a related phenomenon called Trousseau syndrome of migratory thrombophlebitis caused by hypercoagulable states. Sarcoidosis is a multisystem granulomatous disorder of unknown etiology. Hematologic manifestations of sarcoidosis are rare, but as with malignancy, they can include secondary thrombocytosis. Aortic stenosis is associated with acquired von Willebrand disease caused by shear stress-induced proteolysis of von Willebrand factor. A similar phenomenon can be seen in patients with hypertrophic obstructive cardiomyopathy and those with a left ventricular assist device. And the final question of the video, which of the following statements about ITP is true? The correct answer is A. ITP has been associated with both COVID-19 and with vaccination against COVID-19, but not to be confused with the more severe vaccine-induced thrombotic thrombocytopenia, which is a disease that clinically and pathophysiologically resembles heparin-induced thrombocytopenia. Regarding the other answer choices, choice B, a bone marrow biopsy in suspected ITP, is only recommended in patients with concurrent anemia or leukopenia, unexplained abnormalities on peripheral blood smear, or who fail to respond to ITP treatment. Regarding choice C, since we have effective treatments for ITP, the overwhelming majority of patients with ITP die from something totally unrelated. And last, ITP is not a contraindication to most myelosuppressive chemotherapy. That concludes part 2 of the clinical vignettes, and more significantly, it finally concludes this 7-year-long saga in hemostasis. I hope you found this series helpful. If so, please share it with your classmates and colleagues.